Good afternoon. Today we'll be discussing development. So you need to know about development so that as doctors, you will be able to pick up developmental delay early. Developmental delay, if it is picked up early and managed, it can make a lot of difference. And the reason why you should know about development is from your exam point of view. For your practical exam, you'll be having two cases. One case, it will be some system. The other case will be growth, development, and nutrition. So, for the system case, you have to study all the systems. Only then you will get, both the cases carry 12.5 marks. So for the system 12.5, you have to study all the systems. Whereas for the other, if you concentrate on these three, growth, nutrition, and development, you will get the 12.5 easily. So development is very important. So what is development? Development refers to maturation of function, acquisition of various skills for optimal functioning of an individual. That is, a newborn baby, he can only move his limbs and cry. From that stage, all the capabilities of a child. The acquisition of those capabilities, that is development. It reflects the maturation and myelination of the nervous system. Coming to the rules of development, it's a continuous process starting from in utero and progressing in an orderly manner till maturity. Then it depends on the functional maturation of the nervous system. For a child to acquire a particular skill, the nervous system should be mature enough. A child turns over at 5 months. You take a 2-month-old child and repeatedly try to turn it over. The child will not learn the skill. The nervous system has to be mature enough. The sequence of attainment of milestones is same in all children. There is a particular sequence. All children will poo first, then they will say monosyllables, then bisyllables, then they will speak. Similarly, a child will first sit, then stand, then walk. There is that order. So that order is not altered. Then development progresses in a cephalocaudal manner. First, head control has to occur. Head control means if you see a newborn baby and try to make the baby sit, the head will wobble. The baby is not able to hold the neck steady. Whereas by 5 months, the baby is able to hold the neck steady. That is called head control. The first that has to be attained before trunk control. Trunk control means the ability to sit, stand. So there is control of the trunk. That requires control of the trunk. So first head control, then trunk control. So then the control of the limbs. Similarly, the development in the limbs proceeds from proximal to distal manner. So first a child will develop gross control of his limbs, of the hands. Like if you show a 6-month-old child a rattle, he will grasp it with his hands. It is the overall control of the hands. Whereas he cannot use his fingers. There is no fine use of fingers. Whereas at 1 year, there is fine use of fingers develops. If you give a small pellet, a 1-year-old child will be able to pick it up with his fingers. So it is from proximal to distal. The hand overall, then the fingers, like that. Then primitive reflexes need to be lost before a particular developmental skill is attained. There is something called primitive reflexes. You might have heard of Moro reflex. So there are some reflexes that are there in the newborn. Those are called primitive reflexes. Moro reflex, asymmetric tonic neck reflex. So asymmetric tonic neck reflex means if you turn the head of a newborn baby to one side, the limbs on that side will extend, while the limbs on the opposite side will flex. So what the purpose of this reflex is to prevent the baby from falling. Suppose the baby is on a bed and he turns his head to one side. By extending the limbs on that side, the baby is prevented from falling. But this reflex also prevents the baby from turning over. So this reflex has to be lost. It will be lost by 4 to 5 months. Only then will the child be able to turn over. So similarly, palmar grasp, there is something called reflex palmar grasp. If you see a newborn baby's hands fisted together, it's closed always. That is because there is a reflex grasp. And if you keep something, if you keep a rattle in the newborn baby's hand, it will grasp it. It's a reflex grasp. It is not something the baby is doing because he wants to do it. It's a reflex. This has to be lost before voluntary grasp develops. Okay. Then disorganized mass activity is gradually replaced by specific and willful action. That is, if you show a 4-month-old baby a colorful object, what happens? The baby will move all 4 limbs and laugh, and he will be generally excited. Whereas if there's a mass activity, the entire body becomes active. Whereas if you show the same toy to a 3-year-old child, the child will only smile and reach out for the toy. So there is a specific and willful action. Okay. Then coming to the factors affecting development. There are multiple factors which affect development. It can be divided into prenatal factors, the neonatal factors, post-neonatal factors, psychosocial factors. So prenatal factors, that is the factors before that influence a child during intrauterine life, or even before that. That is genetic factors. You all know a child's intelligence will be decided to a large extent by the parent's intelligence. There are so many chromosomal anomalies. You may be aware of Down syndrome. So, if there is a chromosomal anomaly, the development will be delayed. So, like that. Then, maternal factors. Maternal nutrition is a big deciding factor for the child's development. If the mother has malnutrition, the child will have IUGR, and IUGR is intrauterine growth retardation. That will cause developmental delay in the baby. Then, if the mother is exposed to drugs or toxins, like anti-epileptic drugs, they will cause malformations of the child's brain, and the child will have developmental delay. Then maternal diseases like hypothyroidism can cause hypothyroidism in the baby. Then intrauterine infections like congenital CME, cytomegalovirus, rubella, all these HIV, all these infections can cause malformations of the baby's brain and developmental delay. Then neonatal risk factors. That is, if it is a low birth weight baby, it is a cause for developmental delay. Then prematurity. Have you heard of cerebral palsy? Lakshmi.
Spastic.
Yes.
Scissor gait.
Can't hear. It's not clear.
Palsy.
Yes.
Scissor gait.
Okay, I can't hear you. Cerebral palsy is a condition where you get developmental delay. So, when you come to the pediatric wards, you will see children with cerebral palsy. Even 5-year-old children, they will be bedridden. A 5-year-old child with cerebral palsy will not even be able to sit up. So there will be developmental delay. Then they have increased tone of the limbs. They may be increased or decreased tone of the limbs. So that is cerebral palsy. It's a disorder of the motor system due to an injury to the developing brain. So all these low birth weight, prematurity, perinatal asphyxia. Asphyxia is a child does what asphyxia means is the child does not cry at birth. That is perinatal asphyxia. So all these conditions, all these factors lead to cerebral palsy. Then post-neonatal factors. That is beyond the newborn period. The nutrition, malnutrition is an important cause for developmental delay. Then deficiency of micronutrients like iron and iodine. Then infections, mainly CNS infections, meningitis, encephalitis. All these can result in developmental delay, especially if not treated early. Then exposure to toxins like lead, arsenic, mercury, pesticides. And if there is an associated impairment, sensory impairment, hearing is defective, vision is defective, then development will be delayed. Unless there are sensory inputs, the child cannot develop. Then psychosocial factors are also very important in development, like poverty, then violence and abuse. Then there are all the factors we discussed are factors which are cause developmental delay or regression. There are some factors which are protective for development. One is breastfeeding. So breastfeeding promotes brain development. Then maternal education. It has been seen that children of mothers who are better educated have better development. Then coming to the domains of development. So development is discussed mainly in 4 domains: gross motor, fine motor, social, and language. And before you assess these domains, you have to assess the vision and hearing. Because like I said, if the vision and hearing is defective, everything else may be affected. So first assess vision and hearing, then go for the domains of development. So coming first to the gross motor development. That is a gross control of the trunk and the limbs. When you take a case in pediatrics, you start with presenting complaints, go to history of presenting complaints, then there is past history, then antenatal, natal, postnatal. So in the antenatal, natal, postnatal, you ask for all the risk factors that I discussed, the factors affecting development. Was there any maternal hypothyroidism, maternal infections? Did the mother take any drugs? Then how was the delivery of the baby? Did the baby cry at birth? Did the baby have any neonatal problems, seizures, infections? All those things. After that, there is a developmental history. So in that, you ask the mother, according to the mother, when did the child develop the different milestones of development? Now all for domain: gross motor, fine motor, social, language. So you take a history. So, and then after that, after you complete the history, when you come to examination, there is developmental assessment. So in developmental assessment, what you do is, earlier you took a history from the mother. Now you assess, you make your own assessment. How is the child's development at present? You examine the child and ask him different questions and make an assessment. So you have to do both developmental assessment as well as developmental history taking. So if it is a child less than 1 year, when you do a developmental assessment, there is something called 180-degree flip examination. That is, you make the child go through a 180-degree positional change. That is, first you keep the child in the supine position. Then you pull the child to sit, to the sitting posture. Then from pull to sit, then you make the child bear weight and see if he can bear weight. Then hold it in ventral suspension. Ventral suspension means you hold the baby, you support the baby by its abdomen. I'll show you the picture. And suspend it on your palms and see the development. Then there is prone position. So in these 5 positions, you have to assess the baby. So we will be discussing that first. So first, supine and pull to sit. The infant is observed in supine. In the supine posture, you just first observe the baby. Is the baby moving his limbs, turning his head from side to side? Then you pull the child to sitting posture. When you pull this child to sitting posture, there are 2 things you look at. One is their head lag? Is the head lagging behind the trunk? Or the head is coming with the trunk? And the thing is, once you have pulled the baby to the full sitting posture, how is the back? Is it straight? Straight like our back is when we sit? Or is it rounded? So those are the 2 things you look at. So in the newborn period, head completely lags behind the trunk and the back will be rounded. Head control starts by 6 weeks and by 12 weeks, there will be only slight lag. Head control is completely attained by 20 weeks. By 5 months, the baby lifts his head from supine position when pulled to sit and back will be straight. That is, see, in the first picture, you can see there is complete head lag. The baby is being pulled to sit. See, the head is lagging behind the trunk. Whereas in the second picture, you can see, as you pull the baby up, the baby voluntarily lifts the head and the head comes up with the trunk. So this is attained by, it's not 4th month, it is 5th month. It will be complete by 5th month, complete head control. So by what it means is, this is in our assessment. When you do an assessment, this is how you assess the head control. But when you ask history, what you can ask is the mother able to hold the child in her arms with the head without supporting the head? Without supporting the head, is the mother able to take the child on the shoulder? That is what you ask in the history. If head control is not attained, the mother will not be able to do that. So it will be complete by 5 months. Then ventral suspension. That is, you hold the baby in the prone position and then lift the baby from the couch with the examiner supporting the chest and abdomen of the baby with the palm of the hand. See, you can see it in this picture. That is ventral suspension. So at 4 weeks, the head flops down. At 6 weeks, he momentarily holds the head in the horizontal plane. So if you see the first picture, see the plane of the trunk. The head is below the plane of the trunk. This is by in the newborn period until 6 weeks. By 6 weeks, the head will be at the level of the plane of the trunk. It is in the horizontal plane. The head is in the horizontal plane. By 8 weeks, but it is only momentarily. The baby brings the head up to this position momentarily and then the head goes down. By 8 weeks, he will be able to maintain this position. This position will be sustained. By 12 weeks, he can lift the head above the plane of the trunk. See, this second picture is the head is above the plane of the trunk. Then, prone position. If you make a newborn baby lie down, the head will be turned to one side. In the prone position, the head will be turned to one side. And you can see the pelvis is lifted. In the first picture, the legs are flexed and they are beneath the pelvis. That is why the pelvis is lifted up. So this will be there till 4 weeks. By 6 weeks only, the legs will straighten. And by 8 weeks, the baby will be able to lift the head up above the plane of the body. So if you look at the second picture, the shoulders are in contact with the bed. And the head is just lifted up. The shoulders are not lifted above the bed. Only the head is lifted up. That is at 8 weeks. By 3 months, the face, the head, as well as the shoulders, not the entire chest. This picture is not very accurate. The entire chest will, here the chest is also shown as being lifted. By 3 months, the shoulders will be lifted off the bed. 6 months, most of the chest will be above the bed and the baby will bear the weight on his palms. See, the hands are extended and the weight is being borne on the palms. Whereas if you look at the picture of 3 months, the weight is borne on the forearm, not on the palm. The weight is being borne on the forearm. Then by 10 months, the baby will be able to creep with the abdomen off the ground. Then by 5 months, the child can sit with support. That is, he can sit. This is at 5 months, sitting with support. That is a tripod position. It is not at 8 months. It is at 5 months. You can look at the second picture. The child is supporting his weight on the forearm, on the arms. That's like he's sitting like a tripod. That is at 5 to 6 months. By 8 months, he can sit without any support. See, his arms are off the bed. He's sitting without any support. By 10 to 11 months, he can pivot in the sitting position to play around with toys. That is, his control, trunk control is so good that he can even turn around. By 10 to 11 months. Then coming to standing and walking. By 9 months, the child begins to stand by holding on to furniture. By 10 to 11 months, he starts to cruise around furniture. By 12 to 13 months, he can walk independently and walk with one hand held. Between 13 to 15 months, the child starts walking independently. He runs by 18 months, can crawl up or down stairs, pull a doll or wheel toy along the floor. By 2 years, child can walk backwards and climb stairs with both feet on one step. That is, when a child starts climbing stairs, you need to know which are all the milestones. At each age, which milestone develops. You will have to learn it by repeatedly practicing, by repeatedly examining children and referring to your books, and that's the only way you can learn this. But you will have to know the milestones which are learned, which are attained at different ages. So when you coming to climbing stairs, a child at 2 years, he will first climb stairs by putting both his feet on one step. Then he will put one foot on the next step, on the highest step, and bring the other foot also to the same step. That is how he initially climbs. Only after, by 3 years, he will learn to climb stairs one at a time, 1 foot per step, like we do. Before that, he will keep both feet on one step, on each step, and climb. So first, by 3 years, he will be able to climb upstairs 1 foot per step, but not downstairs. Downstairs, he'll still be climbing 2 feet per step. At 4 years, he will be able to climb both upstairs and downstairs 1 foot per step. Then, by 3 years, he can ride a tricycle, hop by 4 years, skip by 5 years. Okay, this is just the milestones. It's given an OP guide, you have to learn. Then coming to fine motor development. So, first, the hand-eye coordination. By 12 weeks, the child brings his hands in the midline and looks at them intently. That is called hand regard. It will disappear by 20 weeks. If it persists beyond 20 weeks, it is considered abnormal. It's a sign that there is something wrong with the child's brain. Then, bidextrous grasp. That is, when you show a rattle to a child, first, he needs both his hands to grasp it. So he will reach forward with both his hands and grasp it. That is called bidextrous grasp. That develops at 4 months. By 6 months, his coordination is better. So he can reach out with one hand and grasp the toy. That is called unidextrous grasp. Then, by 6 months itself, the child will be able to transfer the toy, the rattle, from one hand to the other. Then, so initially, like I said, at 4 months, you test the grasp by giving a rattle. As a child grows older, 6 months, you can give a cue. Then, by 9 months, you can give a pellet. Grasp becomes better, more finer grasp develops as the child grows older. So, when you give a cue, at 6 months, the child will hold the cube with using the ulnar aspect. By 8 to 9 months, he will be able to grasp it from the radial side. And by 1 year, mature grasp of the cube develops. See, in the second picture, the child is holding it on the ulnar side. But by 8 months, he will start holding it with the radial aspect of the hand. So this is mature grasp. And the second picture, the picture below, that is showing what is called pincer grasp. Pincer grasp means grasping something with the thumb and index finger. Pincer grasp is of two kinds, mature pincer grasp and immature pincer grasp. Immature pincer grasp develops by 9 to 11 months. What immature pincer grasp means is that the child will support his hand on the ulnar aspect and then grasp the object with his thumb and index finger. That is immature pincer grasp. He is still grasping it with the thumb and index finger itself. Only thing is he's supporting his hand on the ulnar aspect because his coordination is not so well developed. By 1 year, in this picture, actually it is like the second picture, the child where the child's body is shown. In that, he's reaching out for a pellet. It is almost like immature pincer grasp. His hand is not free. There is some support on the ulnar aspect. Whereas mature pincer grasp means the hand is free and he is grasping the object without supporting the hand in any way. He is grasping the object with the thumb and the index finger. See this picture. This is mature pincer grasp. That develops by 1 year. Then coming to hand-mouth coordination. By 6 months, the ability to chew develops. And stage, he will mouth all objects that are offered to him. Anything you give him, he will put it into the mouth. This will disappear by 1 year. Then, by 15 months, child can pick up a cup and drink without spilling. By 18 months, he can feed himself with a spoon. Then, around 15 months, he can turn. So, to turning of the pages of a book. That also, at first, by 15 months, he'll be turning 2 to 3 pages of a book at a time. He cannot turn 1 page at a time. Later, by 1 year, by 2 years, he will be able to turn 1 page at a time. Then, by 15 months, he will imitate scribbling. Imitate scribbling means you scribble and show, he will do the same. By 18 months, he will be able to build a tower of 2 to 3 blocks and draw a stroke with a pencil. And spontaneous scribbling develops. He is able to do it by himself. Then, by 2 years, he can unscrew lids. That is, lids that have to be turned. Those he will be able to unscrew. Open door knobs and make a tower of 5 to 6 blocks. And turn 1 page at a time. Then holding a pencil, that initially the child holds a pencil, he will hold it in the fist, like this. He will hold it like this. That is by 1.5 to 2 years. Then later only the fine holding, like we hold it, that develops by 2.5 years. By 3 years, he will be able to build a tower of 6 blocks. And he can draw a circle. So this is the drawing skills at different ages. You can go through it. It's given in OP guide. This is also at different ages. You give, when you assess development, ideally you should have tubes with you and you should be able to see what all he can make. He will be able to make more complicated things as he grows older. So at different ages, what all he can make, you can assess. Then dressing. Okay. By 18 to 30 months, they show interest in learning dressing skills. By 1 year itself, the child can pull off caps and socks. When it comes to dressing and undressing, first the child will learn undressing. By 1 year, he is able to pull off cap, socks. By 18 months, he can unzip. And by 2 years, he can undress fully. He can undress, but you have to help with the buttons. The buttons have to be, you have to remove the buttons. Then he can undress. And he can put on socks and shoes. By 3 years, he can dress and undress, but he can also unbutton, but he cannot button at 3 years. By 4 years, he can button. By 5 years, he can tie shoelaces. Then coming to personal and social development. At 1 month, the child develops face regard. What face regard means is that he looks at the face intently. He knows that this is something different. It is not like the other objects. This is a face. And when he sees a face, if you talk to him at 1 month, he will look at your face intently. That is called face regard. A younger child, if you talk to him, he will not focus on the face. There is a first social milestone that develops, face regard. By 1.5 to 2 months, social smile. What social smile means is if you talk to the baby, you smile at the baby, then the baby will smile back. That is social smile. It's not smile back. He will, when you interact with the baby, he will smile. That is his way of interacting with you. So that is social smile. Three months, he recognizes his mother. He quietens when the mother takes the child. He knows it is his mother. At 6 months, if you show him his image in the mirror, he smiles at the mirror image. That is called mirror play. At 6 to 7 months, he shows stranger anxiety. Stranger anxiety means if a person who is not familiar with comes, he cries. That is stranger anxiety. A younger child will not show that. In the wards, when you're examining a 5-month-old baby, the baby will interact very well with you, laugh, make sounds. But when you go and examine a slightly older child, a 6 to 7-month-old child, the baby will cry. That is stranger anxiety. So the first picture is showing a mother, baby looking intently at the mother. That is face regard. Second one is the mother is interacting with the baby and the baby is smiling. Third picture is the baby is being shown his image in the mirror and he is smiling at the mirror. This is stranger anxiety. 9 months, the baby will wave bye-bye and play peekaboo. 1 year, he understands simple questions, comes when called, and plays simple ball games. By 15 months, he points to objects in which he is interested. That is called joint attention. That's a very important milestone. That is, he points out different objects to his parents. That is by 15 months. 18 months, he will be able to follow simple orders and do domestic mimicry. Domestic mimicry means he mimics what his mother is doing. If the mother is sweeping the floor, he will also do the same. Wiping a table, he will also do that. That is called domestic mimicry. By 18 months, he will also be able to point to 3 body parts. That is, if you ask him, where are your eyes? He will point to his eyes, nose, mouth, like that. See, that is peekaboo. The lower picture show domestic mimicry. 2 years, he will ask for food, drink, toilet, and pull people to show his toys. Point to 3 to 4 body parts and 5 to 6 familiar objects. By 3 years, he will be able to identify 1 to 2 colors. He can count to 10 and sing simple rhymes. 4 years, he will be able to identify 3 colors and he develops imaginative play. Imaginative play is like playing with a doll and pretending to feed the doll. Things like that. Then right-left discrimination. He knows right from left. Then 5 years, he will be able to identify 4 colors and repeat 4 digits. Okay. And that in the social milestone, there is also something called parallel play and group play. Parallel play, it is play in children as parallel play, group play, imaginative play. Parallel play means when he sees another child play, he'll sit next to the child and play. Not with the child, but near him and play. That is parallel play. That develops at 2 years. Group play is he will play with the other children. That develops by 3 years. And imaginative play, I told you, that is by 4 years. Then coming to language development. By 1 month, if the child hears sound, he will show some indication that he has heard the sound. He will alert to the sound. By 3 months, he makes, it's called cooing or vocalization. That is, he makes sounds like ah, oo, like that. Ing, the mothers will say ing parayunnunda. So that is at 3 months. 4 months, he will laugh aloud. 6 months, he can say monosyllables, ba, da, pa, like that. So you should know whether it is cooing, it is monosyllables. You have to assess the development of a child. So if it's a 6-month-old child and he's only making these ah, oo sounds, not saying ma, ba, da, that means his development is only corresponding to 3 months. So you should know all the milestones for each age. Only then you will be able to assess. It's a bit boring, but you have to learn it by heart. Then by 9 months, you will be able to say bisyllables, mama, baba, like that. Then 12 months, you'll be able to say 1 to 2 words with meaning. Amma, acha, like that. So what happens is that sometimes these babies, they'll be saying bisyllables, mama, 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 like that. And the mother will say, amma, 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 by 9 months. So you have to ask, is the child saying that only to the mother? Or is he simply saying it? If he's saying it, calling the mother only, then that is word with meaning. He's simply saying, whenever he sees anybody, he's saying mama, mama, then it is a bisyllable. By 18 months, he will develop 8 to 10 word vocabulary. By 2 years, he'll be saying 2 to 3 word sentences. Enikku paal venam, like that. So then he'll also be using pronoun. I, me. 3 years, he asks questions, knows full name and gender, and can say simple rhymes. By 4 years, he can tell stories. Stories means he can narrate events. If he's going to the Anganwadi, he will come and say the events that have happened there. 5 years, he can ask the meaning of words. Coming to vision and hearing. At birth, the baby can fixate and follow a moving person or dangling ring placed 8 to 10 inches away up to a degree of 45 degrees. To range of 45 degrees. This increases to 90 degrees by 4 weeks and 180 degrees by 12 weeks. Around 1 month, the baby can fixate on his mother. At about 3 to 4 months, the child fixates intently on an object shown to him. Binocular vision develops by 6 weeks and is well established by 4 months. By 6 months, the child adjusts his position to follow objects. And he can follow a rapidly moving object by 1 year. Then, newborns respond to sound by startle, blink, cry, quietening, or change in ongoing activity. So, 1 month old child, he will startle when he hears a sound. By 3 to 4 months, he will turn towards the sound. Sound can be produced around 1.5 to test the way whether the baby is hearing. He can produce a sound 1.5 feet away from the ear. By 5 months, he will turn towards the source of sound. That is, if he produces sound below the level of the ear, he can turn towards the source of the sound. He can turn the head to the side and downwards. 6 months, if it is produced above the ears, he can turn towards to the source of the sound. By 10 months, he can look at the source of the sound diagonally. So, at first, he will turn to the sound if it is produced from the side, then down, below, then up, then diagonal. So, this is diagonal localization of the source of sound. Okay. Now, we'll have developmental assessment. Slide. Yes. So, like I told you, after you take the developmental history, you have to assess. You have to make your own assessment to see if the child is doing the various milestones that are appropriate for his age. So, how should you go about it? So, first, it should be a place free from distractions. The child shouldn't be hungry, tired, or irritated. He should be comfortable. You should take some time to make the baby comfortable. Then, first of all, before you go for any formal testing, you can just observe the baby. If it's a younger child, you can see Is he moving his limbs? Is he making sounds? What kind of sounds he is making? Older child, look for his concentration. If he's playing with his toys, look for his concentration and his skills. So you can assess a lot of development by just observing. Then these are the objects you need for a developmental assessment. A red ring tied to a string, that is for the hand-eye coordination. Then red cubes, to see what all he can make with the cubes. Then pellets to test for pincer grasp. And spoon, cup with handle, to see whether he can feed from a cup, spoon. Then a book with thick pages, to see if he can turn the pages. One at a time, 2 to 3 at a time, like that. Then a picture book, you can ask him to identify. Then red pencil and paper, that is to see, test grasp. Paper for scribbling and drawing. And doll and mirror. Mirror is to see for mirror, whether mirror play is there. Okay. So older child, you can make the child draw and see if he has the drawing skills appropriate for his age. Above 5 years, if he's going to a school, you can assess the development by asking him to do asking him simple addition, multiplication, whatever is age appropriate, like that. Then you have to take a detailed history. That is, you have to ask. I told you all the factors that can lead to developmental delay. The prenatal, neonatal, all those risk factors. So ask for take a detailed history. Then also, so then you'll be able to, then you take a, not just this antenatal natal history, also the developmental history according to the parents. That will help you differentiate between delay and regression. I told you about cerebral palsy. In cerebral palsy, there is delay. Child is not attaining the milestones appropriate for his age. A 1-year-old child should be able to stand. He might not be able to do that. But by 3 or 4 years, he'll be able to do it. But regression means the child has attained a milestone. He was able to stand by 1 year. By 1.5 years, he's not able to do that. That is regression. So that indicates a neurometabolic condition. Like you might have heard Tay-Sachs disease, metachromatic leukodystrophy, like that. So you have to be able to differentiate between delay and regression. The management is different in the two conditions. Then you have to form a gross impression about the developmental age of the child. Then examination, main thing is head circumference. So if there is a head circumference appropriate for each age, as a child grows, the head circumference increases. So is he having the head circumference for his age? If the head circumference is less, then it is called microcephaly. That indicates that there could be developmental delay. Then look for dysmorphism. In chromosomal anomalies, you might have heard Down syndrome and all. There will be some dysmorphism. Those children have developmental delay. So if there is dysmorphism, it is an indication that there might be developmental delay. Then stigmata of intrauterine infection. In conditions like rubella, you may have cataract. So look for any stigmata of intrauterine infection. Then hypothyroidism is a treatable cause of developmental delay. So it has to be picked up. So you look for the signs of hypothyroidism, like Coase species, younger child, umbilical hernia, all that. Then vision and hearing. If a child's vision is affected, he will not be able to do anything with his hands. Unless he sees it, he will not be able to reach out or grasp. So assessment of vision and hearing is very important. Then conduct a neurological examination. Okay. Then I told you, a younger child, you should do a 180-degree flip to assess the gross motor development. So when you lift the child up, hold the child in ventral suspension and all, they are very disturbing maneuvers. The child will cry. So all that you do it in the end. First you do the things which will not disturb the child, and then leave these disturbing maneuvers for the end. Also, you should perform a developmental assessment before systemic examination. Then there is something called developmental quotient. That is the average age of attainment of milestone divided by observed age of attainment of milestone into 100. That is, if a 2-year-old child is only able to stand, he is able to stand without support at 2 years. He should be able to do it at 1 year. So average age at attainment of milestone is 1 year. The observed age is 2 years. So it will be 1/2 into 100. The developmental quotient will be only 50%. If the developmental quotient is less than 70%, you say there is a developmental delay. So like we discussed, there are 4 domains: gross motor, fine motor, language, and personal social. So each domain you have to calculate the developmental quotient. And if it is less than 70%, you say that there is delay in that domain. And if there is a delay in 2 or more domains, you call it global developmental delay. Okay. Then when you assess the development of a baby, if the baby's suppose a 4-month-old baby comes to you, you see, is this baby able to do the things that he's supposed to do at 4 months? And if he's able to do it, you say that his development is normal. But a preterm baby, preterm baby's development may be slightly delayed. So suppose it's a baby who is born at 32 weeks. So that is his complete gestational, his intrauterine growth would be completed at 40 weeks. So he's 8 weeks before time. So if he's coming at 4 months, you subtract those 8 weeks. Suppose he's coming at 4 months, you subtract those 8 weeks. That is 2 months. So you're expecting only a development of 2 months. So that is a corrected age. The corrected age for that baby would be 2 months. So the corrected age is used for attaining the developmental, for determining the developmental status till 2 years of age. You do not expect the development of the chronological age. Then if there is gross developmental delay, then like a 2-year-old child is doing only what is appropriate for 1 year, then you can make a diagnosis of developmental delay by a single examination. But then if there is mild delay, then the child may make up. There are variations. So you wait. You just keep the child under follow-up and then decide. Because there are many factors besides the development of the brain, like malnutrition, illnesses, etc., sensory deficit, etc., which can affect the development. So you give a concession for all that. Then dissociation and development is variation in attainment of milestones in individual fields. That is, a child may be normal in the gross motor, fine motor, and personal social, but language is delayed. That means there could be you have to assess for that particular physical disorder. You have to assess for physical disorders affecting that particular domain of development. Like if only language is delayed, that means there may be a hearing deficit. So that is called dissociation, when only one particular domain is affected. Okay. So I told you the child sits without support by 8 months. But you can give that is a normal. But when there is delay, you give a little more time. You give another 2 months. And you make a diagnosis of delay if the child is not sitting without support by 10 months. So these are the upper limits till which you can wait for the different milestones before you diagnose a delay. So for visual fixation following, it is 2 months. Vocalization, 6 months. Sitting without support, 10 months. Standing with support, 12 months. Crawling, 14 months. Standing alone, 17 months. Walking alone, 18 months. He should develop walking alone by 15 months. But you give another 3 months before you make a diagnosis of delay, because there can be variations. Single words, 18 months. Imaginative play, 3 years. Loss of comprehension of single words or phrases at any age. Okay. Then coming to developmental screening. Developmental screening means even if the child's parents do not have any complaints about the development of the child, you screen. You test the child to see if the child is having any delay, so that you can pick it up early. Ideally, all babies should undergo screening. But if that is not possible, at least high-risk babies. High-risk babies are the ones I told you with those risk factors for developmental delay, like babies whose mothers had intrauterine infection, or who have low birth weight, preterm babies, babies who had perinatal asphyxia, or in the postnatal period they had meningitis. So those are the high-risk babies, chronic hyperbilirubinemia. Those babies at least should be screened. So the screening tools used in India are Paediatrics Baroda screening test, Denver development screening test, Trivandrum development screening chart, then the clinical adaptive test or clinical linguistic and auditory milestone scale, and good enough Harris drawing test. So the Baroda screening test, it is the best development screening testing system in India. You can test children up to 30 months. But the disadvantage is that it requires several testing tools and objects. The one that we commonly use is the Trivandrum development screening chart. You can test children up to 6 years using this. It consists of 51 items. So this is the Trivandrum development screening chart. So it is very easy to administer. Here you can do it up to 6 years. This chart is up to 24 months. Then after 24 months, there is another chart till from 24 months to 6 years. So for any particular age, you keep a scale at that age. And you look at the milestones that are written to the left of that scale. So if you keep it at 6 months, the milestones lying to the left are social smile, eyes following pen, holds head steady. So the child should be able to do these milestones. If he's not doing the milestones that are written to the left, the child has delay. So like that for each age, it is very easy to administer. Anybody can administer it. Then the Denver development screening test that assesses children up to 4 years in the 4 domains. This is the Denver development screening chart. Then the clinical adaptive test and the clinical linguistic and auditory milestone scale that is used for assessing child's cognitive and language skills. Can be used up to 36 months. Then good enough draw man test. that requires only a pencil and a pen, and you ask the child to draw a man in the best possible manner. And points are given for each detail that the child draws. It gives a rough estimate of a child's intelligence. See, so you ask the child to draw a man. So at 3 years, the basic thing is to be able to draw the head of the man. That is a circle. So 3 years, he can draw a circle. So the basic score is 3 years. After that, whichever body part he draws, you give him 1 point. And for 4 points, you give 1 year. So like that, you can calculate the developmental age of the child. Then definitive tests. If the screening tests are crude tests. They'll only tell you that there is something wrong with the development of the child. If the screening tests are abnormal, there are definitive tests. So those definitive tests have to be administered to assess, to make a definitive diagnosis of developmental delay. So you just be aware of the names of the definitive tests. They are the Bailey scale for infant development 2, the Wechsler intelligence scale for children, Stanford Binet intelligence scales, and Vineland adaptive behavior scale. Okay. So that's all about development and developmental assessment. If you have any doubts, you can ask. Okay.
Okay, take on live. Well, good evening, students. Today we are going to pass on leg and ankle injuries. I'm Dr. Thomas Koshi from the Department of Orthopedics. A little vast, so but anyway, 4 topics have been chosen. That is plateau fractures, shaft fractures, pylon, and ankle injuries. Okay. So now, tibial plateau fractures. The screen. Tibial plateau is the proximal end of the tibia, including metaphyseal, epiphyseal regions, as well as articular surfaces. AO defines tibial plateau as metaphysis to a distance equal to the width of the tibia at the joint line. The tibial plateau fractures constitute 1% of all fractures and 8% of all fractures of the elderly. Most of the fractures are associated with neurological and vascular injuries, compartment syndrome, contusion, and crush injuries of the soft tissue. And plateau fractures, there are lateral plateau fractures. 55 to 70% of all tibial plateau fractures are lateral plateau fractures. Medial and plateau fractures 10 to 25%, and bicondylar 10 to 25%. Anatomy. Coming to the anatomy, tibial plateau is composed of articular surfaces of medial and lateral tibial plateau on which cartilages menisci are present. The medial plateau is larger in size, it is concave and inferior compared to the lateral plateau, which is smaller, convex, and 2 to 3 millimeter superior. The articular cartilage thickness, the cartilage thickness is 3 mm for the medial and 4 mm for the lateral plateau. Normal tibial plateau has a posterior inferior slope that is 10 degrees. That is the posterior proximal tibial angle. The lateral meniscus is C-shaped. It is attached to the PCL via the ligaments, the anterior ligament and the posterior ligament, Humphrey and Brisbane. There is no attachment to the LCL at all. But the medial meniscus is semicircular, covers 50% of the whole of the plateau. It is thick posteriorly, so promoting posterior stabilization, and is intimately attached to the MCL. The bony prominences near the tibial plateau are anteriorly the tibial tubercle. There is a insertion of the patella tendon, and the quadris tubercle, that is the insertion of the iliotibial band, and anteromedially there is a pace and attachment of the medial hamstrings are to that. The neuromuscular and structures and nearby are the common peroneal nerve, which passes around the neck of the fibula, distal to the proximal tibia fibular joint before it divides into its superficial and deep branches, and the popliteal artery. There is a bifurcation of the popliteal artery into the arterial, anterior tibial, posterior tibial, and the peroneal artery occurs posteromedially in the proximal tibia. The mechanism of injury. The force is directed medially, that is a valgus force, or laterally varus force, or both, causes a split fracture with a collateral ligament tear. An axial compression force always causes a depression. Both axial and force from the sides, that is the valgus or the varus, causes a split plus depression plus a collateral ligament tear. Fractures are classified. So there are 4 classifications which are commonly: HOHL and Moore classification, AO classification, 3-column classification, Dufar classification, and the Sachs classification. But what we usually go for is the Sachs classification. Three-column Dufar classification and the Sachs classification. The clusters classification, that is type 1, is a pure cleavage fracture. It is a wedge-shaped, uncomminuted fragment, is split off and displaced laterally and downward. It is common in young patients. Lateral meniscal pathology may be present. A type 2 is a cleavage combined with a depression. This is a split fracture of the lateral tibial condyle with associated impaction or depression of the articular surface, commonly in elderly and individuals or osteoporotic with osteoporotic bones. Type 3 is a pure central depression, pure depression of the lateral articular surface only. It is common in the elderly. Type 4 is fracture of the medial condyle. These may sprint off as a single wedge or may be comminuted and depressed. Tibial spine is also involved, mostly. Bicondylar fractures of both tibial condyles are split off. Metaphysis and diaphysis retain the continuity. Two fractures with type 6 is plateau fracture with dissociation of metaphysis and the diaphysis. That is, the metaphysis and the diaphysis is also involved. There is a transverse or oblique fracture of the proximal tibia is present, along with fracture of single or both tibial condyles and articular surfaces. Associated injuries, 90% of these fractures are associated with soft tissue injuries. Meniscal tears occur in 50% of all these fractures. Associated ligament injuries, cruciate and collateral, occur in 30% of these fractures. Others are common peroneal nerve palsy and popliteal artery injury. Management, coming to management, you have to, and it is evaluation of the injury and treatment. Evaluation of the injury, clinically, neurovascular examination has to be done to rule out any neurological or vascular injury. That is peroneal nerve or popliteal artery injury. Assessment of any ligament injury, assessment for compartment syndrome, which is very important, and assessment for hemarthrosis. Radiological and evaluation is an X-ray is taken, AP and lateral view. The lateral view is 40-degree internal rotation view, that is to see the lateral condyle, 40-degree external rotation view, that is to see the medial condyle, medial plateau. A 10-degree caudally tilted plateau view to see for the articular surface. A CT can be taken with 3D construction, that is for better visualization and preoperative planning. MRI is useful for evaluating injuries of the menisci, cruciate and the collateral ligaments and soft tissue envelope. Arteriography for any vascular injury in question. Treatment is always non-operative and operative. Non-operative is indicated for non-displaced or minimally displaced fractures without any ligament injury and in patients with advanced osteoporosis. Immobilization with cast or brace for a week, followed by early range of motion and a knee motion in a hinged knee brace along with the traction, skeletal traction. Isometric quadriceps exercises and progressive passive, active assisted and active range of knee motion exercises are indicated. Toe touch weight bearing after 8 to 12 weeks is allowed, and with progression to full weight bearing after 12 weeks. Operative treatment, the indications for surgery are acceptable, and the displacement is controversial. Some doctors recommend surgery when there is an articular step off of more than 2 mm or others more than 5 mm. Some studies reported and similar for operative versus non-operative for articular step off of 8 mm. Instability more than 10 degrees of nearly extended knee compared to the contralateral side is an absolute indication. Open fractures, associated and compartment syndrome, and associated vascular injury. The aim of the surgery is to restoration of the articular congruity, joint stability, and original knee axis. It is to provide fracture stability, allowing for early pain-free movements of knee and mobilization of the patient. To obtain a full functional recovery as a long-term goal, avoidance of post-traumatic arthritis. The principles are reduction and buttressing of the elevated articular segments with bone graft or bone graft substitutes. Soft tissue reconstruction, including menisci and ligaments. Use of a spanning axial fixator as a temporizing measure in people with high energy injuries or significant soft tissue injury. The surgical approaches are usually anterolateral and minimal axis anterolateral, posteromedial and anterior. Anterolateral approach is used for internal fixation of the lateral condyle. Lateral approach, posteromedial approach, and the anterior approach. The implant options are usually the choice of implants is related to the fracture pattern, degree of displacement, and the familiarity of the surgeon. A plate and screw is for buttressing against shear forces or neutralizing rotational forces. A screw alone, simple split, depression fractures elevated percutaneously. One or two screws are enough. External fixators can be used, or thinner plates can be used because of the subcutaneous area. External fixators are a bridging external fixator, hybrid external fixator, and a ring external fixator. External fixation indications are open fracture with severe soft tissue injury, joint instability, polytrauma, severe soft tissue compromise, and serious medical comorbidity. Contraindications are in osteoporosis. It is advantages are it is very soft tissue friendly, fast procedure, restoring them and maintaining and the length. This is a hybrid and external fixator. Now coming to the definitive fixation for the different types of condyle fractures, which we classify by using Schatzker's and classification. So the type 1, which is a pure cleavage fracture, is close reduction with 6.5 mm cancellous lag screw with the washer to gain compression. In young patients, screw fixation is adequate. In elderly, buttress plate is also required. In type 2, via an anterolateral approach, open reduction and elevation of the elevation of the depressed fragment is done. Bone graft is placed to support the elevated fragment. Temporary cave held with the cave wire and fixed with a lateral buttress plate and cancellous screw. First picture, the depressed fragment is being elevated, and then that void gap will be filled with a bone graft, and then a buttress plate is used. There is elevation of the depressed articular fragment because it is a purely depressed fracture, central depression. Elevation of the depressed articular fragment through a metaphyseal window and bone grafting to support the fragment. Fixation is a subchondral and plate or screws are enough. Type 4, Schatzker's type 4 fractures, these fractures tend to angulate in varus. That is because it is a medial condyle fracture. These are fixed with medial buttress plate and cancellous screws. Type 5 and 6. In this type of complex fractures, bicondylar fractures, traditional method of open reduction and plate fixation require extensive exposure, which may compromise soft tissue further and devascularize bone fragments, and this leads to infection. To reduce these complications, less tensile exposures are needed. Indirect reduction techniques by supplementing lateral buttress plate with medial 2-pin external fixator or a small anti-glide plate in place of a bulky medial plate are being used. Nowadays, arthroscopically assisted reduction and fixation techniques are being used with increased frequency for treatment of Schatzker's type 1, 2, 3, tibial fracture, tibial plateau fractures. Now, and coming to rehabilitation, and you need physical therapy, early range of movements, and continuous passive motion. Then strengthening is done by isometric quadriceps exercises, heel slides, and gait training. The complications that you usually see are infection. So the surgery timing is important. Careful soft tissue handling, prolonged exposure, operative time is another cause for infection. You see non-unions, mostly aseptic and septic. Septic are mostly in open type of fractures. And fractures are very, very common. There is arthrofibrosis. So encourage early range of movements and physical therapy. Now, coming to the second topic of Shaft fractures. Shaft and fractures are the most common long bone, and tibial shaft fractures are the most common long bone fractures. More than 5 lakh fractures per year. Most common, it is the most common open fracture also due to the subcutaneous nature of the tibia. It accounts for 4% of all fractures seen. The presentation is symptoms are severe leg pain, inability to bear weight, deformity. On inspection, there is deformity, angulation, and malrotation. Contusion, blisters, and open wounds can be seen. On palpation, there is a fracture capitis noted, and you have to evaluate for compartment syndrome. Look for local soft tissues, and neurovascular examination has to be done. Imaging is, you can take an AP and lateral X-ray. Special investigations are pressure monitoring, angiography, and a CT. Non-operative and treatment and is close reduction and plaster of Paris application to achieve good results. Non-operative treatment is difficult and demanding. Non-operative treatment in plaster can prevent a lateral shift. A POP can prevent angulation, control rotation, but plaster cannot prevent shortening. A plaster, like what Sarmiento said, a fracture in plaster not displace more than its previous maximal displacement. It is usually done for children, undisplaced fractures, stable reduced fractures, and the contraindications for surgery are proper patient and healthcare team. Real fixation options are operation and indirect reduction, which preserves soft tissue attachments, allow movement of fractures as in early union with callus formation. Anatomical reduction, rare, but restoration of the length, axis, and rotation is usual. Nailing is the most commonly done for tibial shaft fractures. So nails function as internal splints. It can withstand heavy loads and can be mobilized, and nails can be mobilized with early weight bearing. The indications are closed diaphyseal fractures, open diaphyseal fractures, segmental fractures, floating knee, and non-unions. It is a treatment of choice for a vast majority of fractures of the shaft or tibial long bones shaft. The complications are malalignment, instability, failure, and malunion and non-union, usually seen in proximal and distal fractures, and after an ILN is done, intramedullary nailing is done. Now, compared to reamed and unreamed nails are mechanically and biologically superior. Reamed nails, there is usually union seen within 15 weeks, and unreamed is 22 weeks. Non-union 0% in reamed, and non-union 20% in unreamed. Malunion is 0, and unreamed malunion is 16% of. You can see in unreamed nails. Screw breakage is more, and in reamed nails is only 4%, unreamed is 52%. So nail breakage is 0%, and you see nail breakage of 4% in unreamed nails. So you can use the compression plating also, but it destroys the periosteal circulation. Direct reduction will destroy soft tissue attachments. Rigid fixation will result in slow union without callus formation. Anatomical reduction is achieved. Implant failure possible if technique is not perfect. Complications due to poor are very, very common due to poor technique. The compression plating indications are simple metaphyseal fractures, corrective osteotomy for a malunion, and plating for hypertrophic non-union. And minimally invasive plate osteosynthesis can be done. It is indirect reduction preserves. The principle is indirect reduction preserves soft tissue, but imperfect reduction leading to malunion is a problem. A bridging plating produces stable fixation, resulting in early healing with callus formation. And this is a photo of a X-ray of a shaft fracture with using a MIPO technique. That is minimally invasive and plate osteosynthesis. The plates cannot withstand weight-bearing forces. The plate will not permit early full weight bearing. Operative shaft using an external fixator, useful in severe soft tissue damage, rarely used in definitive treatment. Soft tissue injury complications and prognosis are directly related to the degree of the soft tissue injury. The complications of tibial nailing specific to nailing are anterior knee pain, thermal necrosis, and iatrogenic fractures. Maybe anterior knee pain may be related to leaving the end of the nail proud. It will not be cured by nail removal unless proximal end of the nail is very prominent. The incidence varies from series to series, 0 to 40%. It's related to surgical approaches, may be more common in patellar tendon splitting approaches. There is high incidence of compartmental syndromes in tibial nailing. There is a high index of suspicion is always supposed to be there. Avoid a local anesthetic techniques. Compartment syndrome, the variable reported incidence in published series occurs in both reamed and unreamed nailing. A high index of suspicion will lead to a high level of diagnosis. Diagnosis is purely clinical and not dependent on any measuring pressures. Now, coming to the tibial plafond fractures, those are also called as pylon fractures. The term tibial pylon was first used by Destot in 1911, likening the definition is all fractures of the tibia involving the distal articular surface should be classified as pylon fractures, except for medial or lateral malleolar fractures and trimalleolar fractures, where the posterior malleolar fracture involves 1/3 of the articular surface. All isolated fractures of the posterior malleoli are considered as pylon fractures. The tibial pylon is the distal end of the tibia, including the articular surface. So, and the limit is, the proximal limit of the tibial pylon is 8 to 10 centimeters from the ankle articular surface. Pylon fractures accounts for 7 to 10% of all tibial fractures. Most pylon fractures are a result of high energy mechanisms. Thus, concomitant injuries are common and should be ruled out. Most common in men 30 to 40 years old. The mechanism of injury is the fracture pattern is dictated by position of the foot and the talus at the time of impact. Plantar flexion injury causes a posterior lip fragment. And when a neutral ankle, there is an anterior and posterior fragment, that is B, and a dorsiflexion injury, there is an anterior lip fragment. Axial compression, that is a fall from a height. The force is actually directed through the talus into the tibial plafond, causing impaction of the articular surface. It may be associated with significant comminution. If the fibula remains intact, the ankle is forced into varus with impaction of the medial plafond. Plantar flexion or dorsiflexion of the ankle at the time of injury results in primarily posterior or anteriorly and plafond injury. A shear fracture, that is usually from a skiing accident. Mechanism is primarily torsion combined with a varus or a valgus stress. It produces 2 or more large fragments and minimal articular comminution. There is usually an associated fibula fracture, which is usually transverse or a short oblique. A combined compression and a shear force, these fracture patterns demonstrate components of both compression and shear. The vector of these two forces determines the fracture pattern. Clinically, the patient typically presents non-ambulatory with a variable gross deformity of the involved distal leg. Full trauma evaluation and survey may be necessary. Most pylon fractures are associated with high energy trauma. Assessment of the neurovascular status is needed. Evaluation of any other associated injuries has to be taken care of. On clinical evaluation, there is swelling, often massive and rapid, needs serial neurovascular examinations as well as assessment of skin integrity, necrosis, and fracture blisters. Meticulous assessment of the soft tissue damage. Significant damage occurs to the thin skin tissue developed surrounding the distal tibia as the forces of the impact are dissipated. Plain X-ray is taken. It is essential to have plain films centered on the ankle as well as films of the entire tibia. The ankle films are AP, lateral, and mortise views. That is to assess the articular incongruity and fragmentation. Tibial films are necessary to fully evaluate the metaphyseal and diaphyseal extent. Proximal injuries may easily be overlooked. Traction X-ray, traction and ligamentotaxis often pull the displaced fragments back into position, allowing for a better definition and understanding of the fracture pattern. CT is used as an adjunct to plain films, shows details often not readily available on most plain films, acts as guide to the articular injury for fracture orientation, fragment location, and amount of comminution or impaction, aids in surgical decision making also. Three classic articular components of a pylon fracture are anterolateral, that is a Chaput fragment, medial fragment, and a posterolateral Walkman's fragment. These fragments vary in their size and amount of comminution. Radiographs of the contralateral side may be useful as a template for preoperative planning. The three most important anatomical zones to be considered in the decision making and prognosis are the articular surface, metaphysis, and the fibula. The associated injuries, because of their high energy nature, these fractures can be expected to have specific associated injuries. Example, calcaneal fractures, tibial plateau fractures, pelvic fractures, and vertebral fractures. The classification most commonly taken is Rudy and Algover. Commonly used today, it is based on the severity of comminution and the displacement of the articular surface. The type 1 is non-displaced cleavage fracture of the ankle joint. Type 2 is displaced fracture with minimal impaction or comminution. Type 3 is displaced fracture with significant articular comminution and metaphyseal impact. There is a mass classification also, that is type A is malleolar fractures with significant posterior lip involvement. Type B is spiral fractures of the distal tibia. Type C is central impaction injuries as a result of talar impaction. OTA classifications not used. Now coming to treatment. Treatment challenges are difficulties in anatomical reduction of the articular surface. Instability may occur due to ligamentous and soft tissue injuries. There is numerous soft tissue complications may be encountered during the treatment. Open surgery is associated with poor wound healing. Restoration of the anatomy is difficult, and delayed union and infections are very, very common. The factors dictating treatment strategy are patient age and functional status, severity of the injury to bone, cartilage, and soft tissue envelope, degree of comminution and osteoporosis, capabilities of the surgeon. Possible treatment methods are conservative treatment with a cast, open reduction and internal fixation, combination of different types of external fixators with or without internal fixation. Strategies for an optimal outcome is anatomical reconstruction of the joint, restoration of the tibial alignment, and stabilization of the fracture to facilitate union. Understanding of the anatomy of the fracture should allow the development of operative techniques and outcomes. Proper length and rotation are critical, as are preserving and maximizing ankle and subtalar motion. Even when these goals are met, there is no guarantee that patients will have an acceptable result. Non-operative treatment is by a long leg cast for 6 weeks, followed by a fracture brace and ROM exercises, range of motion exercises or early exercises, ROM exercises. Indications are non-displaced fracture pattern, severely debilitated patient. Manipulation of displaced fractures is likely to result in reduction of intra-articular fragments. The disadvantages are loss of reduction is very, very common, inability to monitor soft tissue status and swelling. Operative management is for displaced pylon fractures are usually treated surgically. Helfet was the first to propose a two-stage protocol for this type of fracture. In the first stage, a temporary external fixation to restore length, alignment, and rotation of the limb, plus internal fixation of a fibular fracture, if present, and if the soft tissue allows. In the second stage, a definitive surgery is done where the soft tissues, when the soft tissues have recovered sufficiently to limit the likelihood of complications. The timing of surgery is important. Proper timing of the surgery treatment is required to minimize soft tissue complications. Interventions must most respect the underlying tissue and the amount of surgery that the soft tissue envelope can tolerate. Staged procedures are therefore often required to reduce complications and maximize functional results. Staged protocols have been shown to be effective in preventing complications related to soft tissue. Immediate or early intervention is usually limited to stabilization of the fibula with a plate, using transarticular external fixation to keep the extremity out to length and to obtain a preliminary reduction by ligamentotaxis. Definitive reconstruction can be performed at a later stage. Skeletal traction is for more than a few hours have elapsed between the injury and the evaluation. The soft tissue swelling will be too great to allow for immediate and internal fixation. In this situation, a skeletal traction using a calcaneal pin or an external fixator should be used to prevent skeletal shortening while awaiting for soft tissue recovery, which may take days or weeks. Indirect reduction, it helps. Indirect reduction with traction helps to realign the fracture surfaces, which makes subsequent internal fixation easier to accomplish. Placement of the external fixator creates a more optimal environment for soft tissue healing. It is necessary to wait for the reepithelialization of each blister locally and assess the status of the skin until the wrinkle sign of the skin is positive. Associated fibular fractures may undergo oral at the time of fixator application itself. Now, coming to the operative definitive reconstruction. Definitive reconstruction is through open approaches and should be delayed until soft tissue swelling has decreased, as the tissues are tenuous and cannot withstand surgical trauma. Surgery should be delayed for at least 10 days to allow wrinkles to return, blisters to reepithelialize, and wounds to heal. In some cases, delaying the procedure for up to 4 weeks may be required to allow soft tissue swelling to subside. The operative goals are maintenance of fibular length and stability, restoration of tibial articular surfaces, bone grafting of metaphyseal defects, and buttressing of the distal tibia. Articular surface reduction can be achieved percutaneously or through small limited approaches assisted by a variety of reduction forceps with fluoroscopy to judge fracture reduction. The metaphyseal fracture can be stabilized either with plates or with a non-spanning or spanning external fixator. Bone grafting of the metaphyseal defects. That is, internal fixation, like in all articular surfaces, ORIF is the most reliable way to obtain an anatomical reduction of the articular surface. However, this option should be carefully weighted against soft tissue condition. Vascularity might be affected by surgical approach if it's too early. After soft tissue recovery, a limited open reduction and stabilization of the articular component is done with screws alone or with screws and a small buttress plate. The location of the incision and steps of reduction are based on the pre-operative plan. Soft tissue dissection should be minimized and fragments should remain attached to the periosteum and the joint capsule. The first step is the fixation of the fibula to regain the correct length of the tibia and to facilitate the three-dimensional orientation and reduction of the fracture. Whatever surgical routes are chosen, the surgical approach should be centered on the larger bone fragment and care taken not to traumatize the skin with aggressive surgical technique. The distance between the two incisions should not be less than 6 to 7 centimeters or might go for skin necrosis. This is the anteromedial approach, an anterolateral approach, and a posterolateral approach, allowing access to the fibula also. The articular surface is reassembled from lateral to medial and from posterior to anterior. The anterolateral approach of the tubercle is usually still attached to the anterior syndesmotic ligaments and is brought down into position at the time of fibular reduction. Any posterolateral or posterior fragments then are reduced to the anterolateral fragments. The remaining fragments, including are centrally depressed fragments, they are realigned. When necessary, the split medial malleolar fragment can be retracted posteriorly to allow for better visualization of the articular reduction. Temporary fixation is obtained with K-wires and the reduction is confirmed radiographically. Bone grafting of any structurally deficient areas in the cortical or cancellous bone of the metaphysis then should be done. When plate fixation is planned, an anterior medial buttress plate is used. A large spoon or tea plates are no longer recommended as they are too bulky. The first thing in this picture, you can see the first fibula is fixed with a 1/3 tubular plate. Then the other fragments are fixed with temporary K-wires and then screw, and then the deficits are filled with bone graft. Surgical techniques to minimize the plating complications are surgical delay until definitive surgical treatment using initial spanning external fixation for high energy injuries. Use small low profile implants. Avoid incisions over the anteromedial tibia. Indirect reduction techniques to minimize soft tissue stripping and percutaneous techniques for plate insertion like MIPO, minimally invasive. And this is the example of a MIPO where the plate is being slid from the medial malleoli. Now, external fixation can be used as a definitive treatment. This has been of interest in recent years, particularly for its benefits with respect to minimally interference with the soft tissue. External fixators can be either unilateral or circular. They can span or may not this ankle joint and may permit its motion. The principle of treatment with an external fixator is through ligamentotaxis. While most fixators are constructed to provide a tibio-talar calcaneal bridge, circular fixators allow a tibial-only assembly. This can allow early ankle mobilization and, depending on the size and orientation of the K-wires, a juxtaepiphyseal assembly and partial control over the combination of the fragments, which may be assembled under arthroscopic control. The assembly of the external fixator should not jeopardize the attainment of an eventually coverage flap. The pins of the fixator should not be placed along the course of a possible incision site for future surgical treatment. The assembly of the external fixator should, as with internal fixation, be preceded by the fibular synthesis where necessary and if the soft tissue allows, in order to restore the correct length. Articulating versus non-articulating spanning external fixations. Non-articulating the external fixations are most commonly used. Theoretically, allows no ankle motion at all. An articulating external fixator allows motion in the sagittal plane, thus preventing ankle varus and shortening. Application is limited, but theoretically it results in improved chondral lubrication and movement and nutrition owing to ankle motion, and it may be used when soft tissue integrity is the primary indication for external fixation. External fixation is a type of non-spanning external fixator. Fracture reduction is enhanced using thin wires to restore articular surface and maintain bony stability. If an external fixator is used, weight bearing should be delayed until there is a radiographic evidence of bone healing. Arthrodesis seldom performed acutely, reserved only for severe articular comminution, which is not otherwise reconstructible. Best done after fracture comminution has consolidated and soft tissues have recovered, generally performed as a salvage procedure after other treatments have failed and post-traumatic arthritis has ensured. The post-operative management is initial splinting in neutral dorsiflexion with careful monitoring of soft tissues. Early ankle and foot motion when wounds and fixations allow. Non-weight bearing for 12 to 16 weeks, then progression to full weight bearing once there is radiographic evidence of healing. The complications are pylon fractures, especially those caused by high energy trauma, have been associated with high rates of complications. Even when an accurate reduction is obtained, predictably, excellent outcomes are not always achieved, and less than anatomic reductions can lead to satisfactory outcomes. The early postoperative problems are skin necrosis, superficial and deep infection, loss of fixation. Complications with fracture healing, like delayed union and non-union of the metaphyseal diaphyseal junction, varus or valgus malunion of the distal part of the tibia, non-anatomical reduction or post-operative loss of reduction of articular surface. The soft tissue slough, necrosis and hematoma results from initial trauma plus improper handling of soft tissues. For that, avoid excessive stripping, avoid skin closure under tension. Secondary closure, skin grafts or muscle flaps may be required for an adequate closure. Prevalence of post-operative skin and wound problems decreased substantially with the use of the technique of indirect reduction with external fixation and reconstruction of the articular surfaces with small plates or screws or both. Non-union results from significant comminution and bone loss, as well as hypovascularity and infection. Incidence is 5% regardless of treatment method. Malunion, it is very common with non-anatomical reduction, inadequate buttressing followed by collapse or premature weight bearing. Incidence is up to 25% with use of external fixation. Infection. It is associated with open injuries and soft tissue devitalization. Highest incidence with early surgery under unfavorable soft tissue conditions. Late infectious complications may manifest as osteomyelitis, malunion, or non-union. Post-traumatic arthrosis results from damage of articular cartilage at the time of injury. Also associated with fractures in which a congruous articular surface was not restored or maintained. A primary ankle arthrosis is rarely indicated because the long-term outcome is not easy to predict. Although some patients may need an ankle arthrodesis because of symptomatic osteoarthrosis, others do fairly well despite radiographic signs of post-traumatic osteoarthrosis. Then tibial shortening. It is caused by fracture comminution, metaphyseal impaction, or initial failure to restore length by fibula fixation. Then decreased ankle the range of movements. And patient usually is average less than 10% of dorsiflexion and less than 30% plantar flexion. Now, coming to ankle injuries. Now, the anatomy of the ankle joint. Ankle, knee-bone joint composed of the tibia, fibula, and the talus. The talus articulates with the tibial plaford superiorly, posteriorly, superiorly, the tibial posteriorly, and the medial malleolus medially. Lateral articulation is with the malleolus of the fibula. The joints of the foot and ankle are the inferior tibiofibular joint is a syndesmotic joint. This is not a synovial joint, but one covered by a fibrous tissue that holds the joint together. The ligaments are anterior tibiofibular ligament, posterior tibiofibular ligament, transverse tibiofibular ligament, and an intraosseous ligament. These are the ligaments for axial, rotational, and transitional stability. That is anterior, posterior, and lateral. The lateral ligaments are the anterior talofibular ligament, which is the weakest, calcaneofibular ligament, and posterior talofibular ligament, which is the strongest. It limits ankle inversion and prevents anterior and lateral subluxation of the talus. Medially, it is the deltoid ligament complex. It is superficial and deep. Superficial are the tibio-navicular ligament, tibio-calcaneal ligament, and superficial tibio-talar ligament. And the deep are the intra-articular and the deep tibio-talar ligament. They stabilize the joint during eversion and prevent talar subluxation. They are 20 to 50% stronger than the lateral ligaments. This is the deltoid ligament. Inspection, there is always swelling, ecchymosis, and deformity seen. On palpation, find out what is centered, then figure out what is there. That is, knowing your anatomy is very critical. The ankle X-rays to be taken are three views. That is the AP, mortis, and a lateral view. AP view identifies fractures of the malleoli, distal tibia, fibula, plaford, talar dome, body, and lateral process of the talus and the calcaneus. The mortis view is an ankle in 15 to 25 degrees internal rotation. That is to evaluate articular surface between talar dome and mortis. Lateral view is to identify the fractures of the anterior, posterior, tibial margins, talar neck, and displacement of the talus. The AP X-ray identifies fractures of the malleoli, distal tibia and the fibula, plaford, talar dome, body and lateral process of talus and calcaneus. You can see the tibiofibular clear space, which is supposed to be less than 5 mm, and a tibiofibular overlap, which is supposed to be more than 10 mm. The mortis X-ray, it is taken with ankle in 15 to 20 degrees of internal rotation. Useful in evaluation of articular surface between talar dome and mortis. The mortis, in the mortis X-ray, a medial clear space between it is the clear space in between the lateral border of the medial malleolus and the medial talus. It is less than 4 mm, which is normal. More than 5 mm, 4 mm suggests a lateral shift of the talus. In the mortis X-ray, the talar tilt, which is normal, is from minus 1.2 to plus 1.5 degrees, and parallel. Can go up to 5 degrees in stress views, but less than 2 mm difference between medial and is lateral X-ray. Identifies fractures of the anterior, posterior tibial margins, talus, displacement of talus, and osteogonium. Now, stable versus unstable ankle injuries. The ankle is a ring. It is formed by the tibial plaford, medial malleolus, deltoid ligaments, calcaneum, lateral collateral ligament, lateral malleolus, and fracture of a single part usually is stable. Fracture on more than one part is unstable. The classifications are Lug-Hansen classification, Dennis-Weber classification, and AO classification of malleolar fractures. Most commonly, what we use is the Lug-Hansen classification. It is based on a cadaveric study. The first word is the position of the foot at the time of injury. The second word is the force applied to the foot relative to tibia at the time of injury. So if it is supination adduction, supination is the position of the foot and adduction is the force. So the types are supination adduction, the supination external rotation, pronation abduction, pronation external rotation, and pronation dorsiflexion. The Lug-Hansen classification advantages are characteristic fibular pattern. It is useful for reconstructing the mechanism of injury, a guide for close reduction, and a sequential pattern, inference of ligament injuries also. The disadvantages are it is very complicated, variable, inter-observer relatability, doesn't signify the prognosis. Internal rotation injuries are missed and doesn't indicate stability. In Lug-Hansen, the supination adduction type, that is stage 1, the fibula fracture is transverse below the mortis, and stage 2, medial malleolus fracture is classic vertical pattern. The supination external rotation, there is stage 1, there is anterior tibiofibular ligament is torn. Stage 2, there is a fibula fracture. Stage 3, there is posterior malleolus fracture or a posterior tibiofibular ligament tear. Stage 4, there is a ligament, the deltoid ligament tear or a medial malleolus fracture. Pronation abduction, there in stage 1, there is transverse medial malleolus fracture distal to the mortis. Stage 2, posterior malleolus fracture or a posterior tibiofibular ligament tear. Stage 3 is a fibular fracture, typically proximal to the mortis, often with a butterfly fragment. Weber's classification. It is based on location of the fibula fracture relative to mortis and appearance. Weber type A is fibula fracture is distal to the mortis. B is fibula fracture at the level of the mortis, and the C is a fibula proximal to the mortis. The concept is the higher the fibula, the more severe is the injury. Classification is the 3 types: infrasyndesmotic, transsyndesmotic, and suprasyndesmotic. What's classification? It is easy to remember. First degree is unimalleolar, second degree is bimalleolar, and third degree is this trimalleolar. Potts fracture, a common term for bimalleolar fracture. In the Pott fracture, the fibula is fractured above the intact distal tibiofibular syndesmosis. The deltoid ligament is ruptured and the talus is subluxed laterally. The history it is in this British surgeon's Percival Pott. He himself got this injury after a fall from a horse, and TB spine is also named after him. The initial management is to reduce the talus underneath the tibia. If the joint is very stable, slab can be applied. The other options are spanning external fixator or a calcaneal pin traction, rest, ice, and elevation. use of continuous cryotherapy and intermittent pneumatic pedal compression pumps. The factors that affects the outcome are the medial plafond impaction fractures with vertical malleolar fractures, posterior malleolar fractures, anterolateral corner of the profound fractures, and the level and displacement of the fracture fibula. Post-treatment is used in stable ankle fractures, usually with only fibular fractures. Immobilization in cast for 4 to 6 weeks is the preferred treatment. The indications for surgery is inability to obtain or maintain an anatomic mortise, that is an unstable fracture pattern, and open fractures. The general considerations are a limited soft tissue coverage. Lateral malleolar fractures, avoid injuring the superficial peroneal nerve. Make sure that the distal fibula is fully out to the length. Laterally comminuted pronation abduction patterns are most difficult. For maximum stability, place plate posterior. These are different implants used for the fixation. For a medial malleolar fixation, a 4 mm partially threaded screw works well. Screws should be perpendicular to the fracture line and parallel for maximal compression. Spread 2 screws for good stability. Use fluoroscopy to be sure screws are clear of the joint. Any small fragment or tension band wiring along with screws can be used. If there is a deltoid ligament tear, the deltoid ligament, especially its deep branch, is important to the stability of the ankle because it prevents lateral displacement and external rotation of the talus. X-ray will show displacement and tilting of the talus with increased medial clear space. A 1 mm lateral shift of the talus can reduce the effective weight-bearing area of the talotibial articulation by 20%, and 5 mm shift can reduce by 80%. It is repaired with non-absorbable sutures. Syndesmotic fixation indications are syndesmotic instability after fixation of the malleolus. Consider it if the fibular fracture is more than 4 cm above the joint line and there is a masonry fractures also. Have a bone hook on the back of the table to check the stability. Have large fragment screws and instruments available. The surgeon's choice of large or small fragment fully threaded screws, 1 or 2, are used. Not inserted as lat screws, but as a positioning screw. The threads are to engage all the cortices. Secures position of the fibula next to tibia, allowing torn syndesmotic tissues to heal. It may be removed in 6 to 12 weeks. A below knee posterior slab for 5 days with elevation, followed by full POP walking cast for 6 to 8 weeks. Early complications are vascular injury and bone breakdown and infection. Late complications are malunion, non-union, stiffness, and osteoarthritis. The expected time of bone healing, extraarticular malleolar are 6 to 10 weeks, and intraarticular malleolar, bimalleolar, or trimalleolar are 8 to 12 weeks. Expected duration of rehabilitation after cast removal is, for extraarticular malleolar, it is 12 to 16 weeks. For intraarticular malleolar, it is 16 to 24 weeks. Fracture variants you should be knowing about are the masonry fracture, which is a fracture of the proximal fibula with syndesmotic disruption. The Walkman fracture, that is the fracture of the tibial attachment of the posterior tibial fibular ligament. And a posterior malleolar fracture type. Then there is a Tilloch-Chaput fracture, which is a fracture of the tibial attachment of the AITFL. That is the anterior-inferior tibiofibular ligament. A masonry fracture is a fracture of the proximal fibula with syndesmotic disruption. A Walkman's Diputerin's fracture. This fracture usually occurs 2 to 7 centimeter above the distal tibiofibular syndesmosis with disruption of the medial collateral ligament and typically tear of the syndesmosis leading to ankle instability. In the low variant, the fracture occurs more distally and the tibiofibular ligaments remain intact. Vasgap Liffordt fracture. In the Wagstaff Liffordt fracture seen here schematically on the anteroposterior view, the medial portion of the fibula is avulsed at the insertion of the anterior tibiofibular ligament. The ligament, however, remains intact. Fracture is an avulsion fracture of the distal portion of the medial malleolus. Injury may continue and rupture the deep deltoid ligament. A Bosworth fracture dislocation is a fibular fracture with posterior dislocation of proximal fibular segment behind the tibia. And not so common is a trimalleolar fracture which can be caused by talar eversion and posterior displacement, also known as Henderson fracture. It is a fracture of the ankle that involves the lateral malleoli, the medial malleolus, and the distal posterior aspect of the tibia, which can be termed as the posterior malleolus. The trauma is sometimes accompanied by ligament damage and dislocation. Treatment is always surgical with open reduction and internal fixation. Thank you. Any questions? Gayatri Jayakumar, what is a Potts fracture? Okay, come on. Akhil? Okay, thank you.